Thank you very much. I think I'm mic'd up, so I'm going to just do a little test here. Yes, I can take it on a road test. That's awesome. It is a pleasure to be here. This is my first time ever to the province of Nova Scotia. So you have been all very welcoming, and I will certainly be coming back during the summertime with family so that we can actually explore this lovely province. Part of the theme of this meeting seems, as it is emerging, to be the outreach to collaborate. And this is really kind of cool because there have been entrenched schools of thought about Lyme disease, and I decided to entitle my talk Bridging Differences, and I'm pleased to see that the theme that I chose seems to have permeated with every presentation that's gone on, is everyone's wanting to reach out and make things better. Disclosures. I forgot to put a disclosure slide, which is, really remiss for an academic. So my disclosure, I do have some honoraria that I received from diabetes companies, and specifically with respect to diabetes and kidney disease, but nothing with respect to Lyme disease. So I'm going to put on my law hat at the beginning here and try and help a few people with maybe some trepidation that they have about what they're meant to be doing with the management and treatment of Lyme disease. And that is, what am I expected to do, or what is the standard of care that I'm being held to? And I'm not sure how well these are going to project. You're not meant to read anything in any of my slides except the big print. The little print I'll fill you in about. So the IDSA guidelines published in 2006 do not define the legal standard of care that you're meant to practice. And in that IDSA guideline piece is this disclaimer in the bottom left-hand column of the title page. You might be able to read there the "it is important to realize" statement. That guidelines are not meant to be, I have to stay away from that, right? Okay. Guidelines are not meant to be rules, they're meant to be guidelines, and the application is meant to be colored by the physician's interpretation of the patient's individual circumstances. So there are some legal principles that have evolved in common law that apply to the standard of care. And again, you're not meant to read all of this stuff. The middle paragraph here is the important paragraph, and that is that a doctor need not follow the procedures adopted by a unanimous majority of doctors. If a doctor follows a procedure adopted by a reputable minority of practitioners, it will suffice to disprove any inference of negligence. And then it goes on to list precedents, etc. So as long as the practice that you follow is a practice that is followed by a reputable minority of your colleagues, there is no inference of negligence. And in a recent ruling, Queen's Bench in Alberta, in a wrongful death suit, the obligation to diagnose and treat a patient was identified by Justice Shelley as follows. A key feature of the differential diagnosis process is elimination of the most serious ailments first, rather than the most probable, which is referred to as the worst first principle. Choosing a diagnostic process based on probability rather than severity is fundamentally flawed and negligent. They go on to say that failing to consider the worst first principle and failing to carry out appropriate tests to confirm or eliminate the worst of the potential diagnoses is not a mere error of judgment, but rather a breach of the standard of care. And this one I made bigger so that you could actually read it, and I forgot to pull it up while I was reading it, so I'm sorry. So the standard of care has been defined by the courts with that statement. The College of Physicians and Surgeons of Ontario recently released a letter publicly that outlines the duties with respect to Lyme disease. In Ontario, their college does not communicate specific expectations for the treatment of Lyme disease. They don't endorse any particular guidelines. Physicians who treat Lyme disease are expected to practice in a manner that is informed by evidence and science, and that is in keeping with relevant professional, ethical, and legal obligations. And I mentioned the legal obligations at the outset. And the foremost obligation is the obligation or the duty to act in the best interest of the patient. So the best interest of the patient is the yardstick that we're meant to be measured against. When we look at the diagnosis of Lyme disease, taking my lawyer hat off now, maybe, it's starting to come off. We have Lyme disease that can be clearly, definitively diagnosed without any dispute. And that would be definite Lyme disease, and that is meant to be a red circle that identifies the very definite Lyme disease that can be diagnosed. A penumbra around that are patients who probably have Lyme disease. And in law, probability is defined as being on the balance of probabilities, or 50% plus 1 or higher. So the probability of having Lyme disease is a group of people where that orange group would not contain 100% Lyme patients, but each of those patients would have more than 50% individual likelihood of having Lyme. And then another penumbra around that would be the plausible Lyme patients. And in medical sciences, we generally use a 95% confidence interval. So if you could say that I can rule out Lyme disease with greater than 95% confidence, you'd be outside of that yellow circle. But if you cannot say that you can rule out Lyme disease with 95% probability, you would fall within that yellow circle, even if your personal circumstances had your likelihood of Lyme disease less than 50%. So with that scenario, let's now think about a case. So I'm going to give you consideration of a case of a 21-year-old college student attending Acadia University who discovers an embedded tick on their leg. It has been embedded for less than 12 hours. The tick was removed uneventfully and it was non-engorged. 6 days later, the student developed flu-like symptoms, had swollen lymph glands, a low-grade fever, a headache, and muscle aches and pains. And because of that, presented to student health. Objectively, there was no skin lesions, there were no cranial nerve abnormalities. But the physician there elicited the history of the tick bite and considered the possibility of Lyme disease as being plausible, given the presentation. The physician was aware that serology shouldn't be tested for at least 2 weeks following a bite, and so a requisition form was given to the student for testing to occur after that 2-week window evolved. And when the testing was done, the initial ELISA, called C6, tested positive. The specimen was sent along for a confirmatory Western blot analysis, and the Western blot was reported as negative. Now, what are some of the important elements of the case that I've just outlined for you? Well, first of all, the student attends Acadia University. And that's an interesting geographical place. This is a study that is in the literature from 2011 from the Public Health Agency of Canada scientists identifying the genotypes or the different subspecies of ticks that have been identified by surveillance in Canada. And what they identified was that there were 17 specific genotypes identified in Canada. Each of the genotypes is identified by a letter of the alphabet. And I have put little asterisks over the more prominent ones. A, B, G, I, K, and N. Could you hand me my water bottle, please? I'm sitting here running out of spit. I get what you say, Todd. I mean, it's scary up here. Awesome. So I was looking at these 6 different genotypes, and I was trying to come up with a mnemonic that would help me to remember them. And the word baking actually works. So A, B, I, G, N, and K. So we've got baking. So I'm going to call these the baking group. Nobody else in the world is going to call this the baking group of genotype, but I will. So the student is attending Acadia University, and this particular surveillance or study that was done by Nick Ogden and his group identified that all 17 known alleles were represented in the sample, but a spatial cluster of ticks carrying allele I was observed in Nova Scotia, centered on 45.09, 64.37, with a 67 kilometer radius. Now, they don't tell us anywhere in the body of this paper where that is. How many people, well, you probably know, but how many people would have known where that was before I told you about Acadia University? Because that's Acadia University's coordinates. And this is the representation of this cluster of I genotype ticks in 2011 from their paper. I'm just going to mention as a silly aside, I noticed that the Lyme disease map for Nova Scotia is getting darker and darker and darker blue. And my recollection from October 22nd is that Nova Scotia was clearly not blue. It was very red. Sorry. So public health officials would advise that because this was a non-engorged tick and was attached for less than 12 hours, the predominant teaching would be that this is a low risk or a zero risk tick bite. And I would just make a dispute with that. This is a prospective study that was done in the Netherlands and reported in 2013, and it identified a population of people who were prospectively looked at in a group of general practices. People who developed erythema migrans rash were identified by how long their tick was attached for. And in this particular study, over a third of the erythema migrans rashes that emerged from tick bites that were less than 24 hours, and 20% of them were tick bites that were attached for less than 12 hours. So this is human experience, and it was prospectively collected. The same group in the Netherlands has gone on to develop an interesting mathematical model identifying the risk of getting Lyme disease based on the characteristics of your tick bite. And the likelihood of having Lyme disease increases with the duration of time that the tick is attached. It increases with the engorgement of the tick, and it increases whether the tick is positive or not for Borrelia. This tick was not engorged, but here is the risk map that was identified in that study. I'll make it as big as I can on the slide. And this is where the section on engorgement is. And so a non-engorged tick attached for less than 12 hours would still contribute a 1.6% likelihood of Lyme disease as the risk associated. Dr. Gary Wormser, who is a Lyme researcher, has looked at the effect of the genotype of your Borrelia on the positivity of test behaviors. And what he's identified here is the different tick genotypes, and you'll see that depending on which genotype of tick you have, the C6 test, the first screening test, and the Western blot test results are affected quite significantly. I've put little blue arrows by our baking group, and I'm going to look specifically at genotype I, which is, as you can see, halfway down. Very strong response with the C6 test, but a pretty lackluster response for the two-tier testing. And so applying the Bayes theorem, which all of us probably survived in medical school, Bayes theorem being the mathematical assessment of the post-test likelihood that you have a disease, using these equations. I'm not going to bore you with doing the math because there is a calculator. So the pretest probability of Lyme in this case is 1.6%. The sensitivity of the C6, if it was genotype I, which is the predominant genotype in that geographic area, would be 90%. Specificity of a C6 is 95%. And the post-test likelihood with the C6 is there's a 22.6% likelihood that this student has Lyme disease as a result of this tick bite. Falls into the yellow zone on my probability map. Now we go ahead and we do the Western blot study with a pretest probability of 22.6% now. That Western blot is only a third sensitive. Very specific, but only a third sensitive. When we do the math with a negative Western blot, that individual has a 16.5% likelihood of Lyme disease. So what's the implication? Well, the guidelines, your Ministry of Health, the Nova Scotia Infectious Disease Expert Group have all published guidelines that would suggest that this should be considered negative for Lyme disease and another diagnosis should be pursued. But the legal test is to do what is in the best interest of the patient. So I will leave you with a question, not a statement. Is it in the best interest of a patient with a 1 in 6 likelihood of having Lyme disease to pursue a different diagnosis and to discard the diagnosis of Lyme disease? Now, the map I showed you with genotype I was a map from 2011. And we know from Ontario data that the migration or the expansion of a tick range occurs about 46 kilometers each year, the range expands. So in the 8 years since 2011, we would expect the range to have expanded by 380 kilometers. So I was curious to see what would it look like to have a map of the Maritimes with a 400 kilometer radius around Wolfville. And that's what it looks like. We have inclusion of the entire province of Nova Scotia. We have the entire province of New Brunswick. We start to erode into Maine, and I forgot all of my geography from grade school, so I had to look things up, but that is the Gaspé Peninsula of Quebec. So it's a widely expanded area. A positive C6 test in an endemic area means that you should take it seriously. If you have a positive C6 in an endemic area, there's no second confirmatory test that is sensitive enough to allow you to rule out Lyme disease from your differential diagnosis if the test is negative. So employing or engaging the rules that Justice Shelley put forward in Alberta, that you must either eliminate or confirm a diagnosis, there's no test that allows you to eliminate Lyme disease once you have the scenario of a positive C6 test. And failing to address the worst first diagnosis has been called by the courts fundamentally flawed and negligent. In Nova Scotia, between 2011 and 2015, over on the right-hand panel there, you can see 248 positive confirmed Western blot studies out of 476 C6s that were submitted. That means that 228 Nova Scotians in that time frame were told they do not have Lyme disease despite having a C6 positive. I wonder, in all 228 cases, where the likelihood of Lyme disease exceeded 5% and where they fell within that yellow zone, was the individual interest of that patient taken into consideration? And were they informed that they had a post-test likelihood of Lyme that exceeded 5%? Those are questions. I'd like to talk real quickly about the application of this testing in a study that's been completed in Atlantic Canada. This was a study looking at Lyme disease diagnosis or Lyme disease serology in multiple sclerosis patient population. This was a study that included 90 patients attending an MS clinic. They had ELISA done initially, to see whether or not they had the first stage test result for Lyme disease, and then 6 positive test results had the Euroimmune test applied to substantiate whether or not Lyme disease diagnosis could be substantiated. And 6 out of 90 had serum that was reactive to C6, and 0 were positive by the Western blot. So let's have a look at the analysis of this now with Bayes' theorem. The MS study showed 6 negative test results out of 90, and so that would give the C6 in this study a 93% specificity. But this falls well below the specificity that has been defined by Government of Canada meta-analysis, etc., where the late stage C6 should have a specificity of at least 98%. So looking at this deductively, one would expect that of those 6 specimens, 4 ought to have been positive to get the specificity closer to 98%. The Euroimmune testing has a sensitivity and specificity that are shown there. So if we take the 66.7% likelihood of Lyme disease if you're C6 positive in this population, and we apply the Euroimmune, and we get a negative test result, that still leaves each individual with a 13% likelihood of having Lyme disease. Or, to say it another way, an 87% likelihood for each individual that that negative test result is right. And so what's the likelihood that 6 people in a row would all have that test result? Well, it would be 87% times 87% times 80% 6 times, which is 43.3. So the likelihood that this survey has accurately described a population who have 6 C6s as positive is 43%. On the balance of probabilities, the stated conclusion of this study is wrong. The stated conclusion has a 56% likelihood of being actually incorrect. So how do you properly analyze studies that have got small numerators? This has been described by James Hanley. He was a professor of mine at McGill who was an instructor in statistics. And this is the formula that defines the confidence interval in a study when there's 0 or a very small numerator of positive results. And if we do that for this MS study, we come up with the 6 positive screened C6s. We allow for a couple of them to be false positives, but we observe 4 results that would be consistent with true positives. We would calculate the confidence interval, and we'd come up with up to 10% of this population being plausibly showing Lyme disease positive serology. So the conclusion of this study as it was written and published was that the seroprevalence of antibodies against Borrelia burgdorferi in the cohort was 0 by the IDSA 2-step algorithm, and that is correct, that is accurate, and that is the way a reporter would report it. But the interpretation of a clinical study needs to include in the conclusion statement analytical aspects as well. And I would propose that this would more comprehensively discuss what the findings show. With 95% confidence, the analysis of this cohort can rule out greater than 10% seroprevalence, but because the likelihood of all of them being 0 is less than 50%, on balance of probabilities, the cohort cannot be described as being all negative. Single-dose prophylaxis is going to finish me off here, so this will be the last one. So the CADTH organization, that's the Canadian Agency for Evaluation of Drugs Technology for Health, did an analysis of the 1-dose prophylaxis for Lyme disease in May of this year. And what they identified was that there was only one study that identified benefit of prophylaxis. They found a number of issues. The effectiveness estimate has a wide confidence interval, and if even one of the 26 patients lost to follow-up and the treatment group developed an erythema migrans, the effectiveness would no longer be statistically significant. That's important. The use of erythema migrans as a surrogate outcome for Lyme disease has not been validated. The length of follow-up was insufficient to detect late manifestations of Lyme disease. The trial is also ungeneralizable to patients bitten by other black-legged ticks, patients exposed to multiple tick-borne diseases or manifestations of Lyme disease other than erythema migrans. And finally, they said that a medical entomologist was used to identify their ticks. So here is a data table from that actual randomized controlled trial. This data table is the data table that identifies why they came up with the recommendations that they did. You can see on the very bottom line there where it says all, that 1 out of 235 patients treated with doxycycline evolved an erythema migrans rash at the site of their tick bite, and 8 in the placebo group, and this was statistically significant. The next table in the same paper, though, identifies that there was erythema migrans that emerged away from where the tick bite was. In one instance, in both the doxycycline and placebo group, and if you look at the p-values in table 3 there, there's no difference between doxycycline and placebo for things like developing post-bite acute illness, seroconversions, febrile episodes, etc. And indeed, one of the doxycycline individuals seroconverted even though they got their prophylactic dose. If you take the erythema migrans multiple at distant sites and add them to the other group, we end up with a statistical analysis that shows that this is no longer statistically significant. So a single dose prophylaxis might reduce the occurrence of erythema migrans at the site of your rash or at the site of your bite. That doesn't mean that you're not getting Lyme disease. And in fact, the benefit of this was only demonstrated if your bite was from an engorged nymphal tick. It identified that it reduced the emergence of erythema migrans. But keep in mind, erythema migrans is the only clinical sign of Lyme disease that we can make a clinical diagnosis reliably. So you're removing the practitioner's ability to make a clinical diagnosis. And doxycycline impairs the acute antibody response to the infection as well. So you're reducing the sensitivity of your serology. So the whole approach of using single-dose prophylaxis unwittingly biases the entire situation away from making the diagnosis of Lyme disease if it emerges. You're cloaking the clinical diagnosis, and you're reducing the sensitivity of your serologic tool. I'll close by just talking about Lord Kelvin. Lord Kelvin, or William Thomson, was a highly respected scientist. He pioneered underwater transcontinental telegraph lines. He invented the Kelvin scale of thermodynamics. A very respected scientist in the Victorian era. And when he was president of the Royal Society of Edinburgh, he said, "Heavier than air flying machines are impossible." So very prestigious people can say things that are later proven to be incorrect. Orville Wright said, "If we all worked on the assumption that what is accepted as true were really true, then there would be little hope of advance." And Henry Ford, much as I probably don't want to be quoting a Nazi sympathizer, when everything seems to be going against you, remember that the airplane takes off against the wind, not with it. I'm very happy to present to you. I know that much of what I've said is perhaps controversial. I say this with the greatest respect to try and advance our knowledge of Lyme disease and treat patients properly. Thank you.
I expect that we have questions, and I see the mic has already been passed, so please introduce yourself.
There. Thanks, Dr. Hawkins. My name's Lynn Johnston. I'm an infectious diseases physician in Halifax. So thank you for coming to cold Nova Scotia from what I think is warmer Alberta.
You're welcome.
I just have a quick stem, if I might, to my question. And as I read the case about the Acadia patient, I thought, oh no, this is not what we try and teach in Nova Scotia. We've kind of de-emphasized focusing on an actual tick bite and talk about a tick endemic area and assume that if you live in a tick endemic area, you have had a tick bite, and the bite you recognize might not be the bite that gave you the infection you had. So that's the first thing we teach, try and teach. And the second thing is the whole issue about when the test becomes positive, and we would never say 3 weeks is it. So my question is, what specifically do you do in Alberta to try and enhance your educational strategies for everyone, realizing that physicians have a whole lot to learn, and how do we make an impact with some of our key messages? What do you find has worked?
So I can't come to you in Nova Scotia from my home in Alberta and tell you anything about tick-borne disease strategies or education. My public health officials are still of the school of thought that says we have no endemic transmission of Lyme disease ever recorded in the province of Alberta. And so that is the current state of affairs in Alberta. And while we do have endemic tick populations with close to 20% of our local ticks having Borrelia burgdorferi, the ticks in Alberta are predominantly dog ticks and not predominantly black-legged ticks, and so the overall burden and likelihood of transmission with a tick bite in Alberta is still too low for any useful education to have occurred. So I'm coming to you from what is the Lyme disease hinterlands.
Right. I mean education in general, not necessarily specific to this.
Okay, so education in general, I would simply ask that if you're living in an endemic area and you have a patient where the differential diagnosis includes acute Lyme disease, that you should treat it. And I think Dr. Lambert pretty much was making the same plea, is that early or acute Lyme disease should be treated if it enters the differential diagnosis. The answer to that is I don't know. I met with a group of physicians on Thursday night after I arrived in Halifax, and pretty much uniformly there was agreement as we talked that people feel dissuaded from making the clinical diagnosis, they feel unsupported in making the clinical diagnosis, and they feel unsupported in embarking on antibiotic treatment that would be quite appropriate given the individual circumstances if they don't have laboratory support of that judgment. So I think having physicians like you and having physicians like Dr. Hatchett and Dr. Cram giving the messaging that clinical diagnosis is valued and that the treatment of Lyme disease in early stages, if it falls into the orange or yellow zone, I mean, you're not going to be fettered with being 100% right all of the time. Somebody at risk should be treated, and that messaging, I think, is valuable to get out there. I think the Ministry of Health probably can still make some progress with their educational materials to help with that. A 24-hour attachment time is not proper teaching, in my view, given the human experience in Europe.
It was just, in view of the uncertainty surrounding testing, I was just would be interested in a comment regarding the integrity of our blood supply for transfusions and that sort of thing. How do we test these specimens to make sure that we're not transmitting it or inadvertently in transfusions?
I am aware that Borrelia can survive the process of storage of banked blood. I know that the Red Cross does not test specifically for Borrelia antigens when blood is donated, and I am personally unaware of any more than maybe one case of a transfusion-associated Lyme disease occurrence in Canada. That one case was reported, I think, in the late 1980s or early 1990s that I'm aware of. It has not happened to the best of my knowledge in terms of documentation. Is it a theoretical risk? Yes. If something is a theoretical risk for human health, then there should be a precaution of some sort engaged. I don't see that that precaution has been engaged. So I think from a legal perspective, if someone were to develop transfusion-associated Borrelia with the current state of knowledge, there would be concern about that occurrence. But it's extraordinarily rare if it happens at all. Todd, I know you will probably want to respond to that too.
So there has been a survey from CBS looking at Borrelia and Babesia and including Nova Scotian patients. And they didn't find any. So as Ralph said, is the diagnostics perfect? No. So then if we take the precautionary principle, the way that CBS deals with potential risk is they exclude. So that means everybody in an endemic area would have to be excluded from blood donation. What is the risk to the people who are undergoing surgery or immune-compromised conditions that need blood products if we exclude everyone based on a theoretical risk? So that would be my only comment there.
We have another question, and I just would remind people to please identify yourselves. That's helpful to us. Thank you.
I've got a question here. My name's Brian Raid. I'm a naturopathic doctor. It was a great talk. Thank you. Just kind of a dovetailing point on the first question. I've been observing, as I'm sure most people in the room have been observing, over the last little bit, you can't, listen to the radio, read local publication without coming across a story about Lyme disease. Some of them are a bit on the controversial end of the spectrum, but there definitely seems to be media interest and willingness to talk about Lyme, and I feel like any one of the wonderful MDs that are here in the room today who said, hey, I want to go on the Rick Howe Show. I have no affiliation with the Rick Howe Show, by the way. Or I want to talk to the Chronicle Herald. I think they would just jump at the opportunity to hear, especially a public health official saying, Lyme is a clinical diagnosis and ultimately just getting it out there, kind of dispelling some of the taboo about, like, as was said, like physicians evidently are a little bit hesitant to prescribe the doxy just based on clinical diagnosis. So what are your thoughts about that?
I think public awareness is important, and public awareness will be heightened with media cooperation. The opportunity to speak to the media is sometimes a little bit colored because they're often trying to create controversy and confrontation when neither confrontation or controversy, I think, are constructive. So I'm always cautious whenever I speak to media to make sure that the messaging does not become confrontational.
Other questions?
So just to demonstrate how much I love you all, because I sincerely have come here out of a sense of duty to my profession and love for you as patients. I will be missing the Saskatchewan Roughrider Winnipeg Blue Bomber playoff game because I will be at 38 or 40,000 feet and not able to watch the game. So this is big for me. So thank you very much.